comprehensive talk. Now is the time for the surgery. Go the right, the new surgery at Shah Teaching Hospital. Brain death in neurosurgical practice is the title of the talk.
Today I'm going to speak about the experience and experience of our department in diagnosing brain stem here in Sudan, which we usually use to face from time to time. The first case is an 8 years patient. He's a retired professional and from Omdurman. He presented with sudden fall with loss of consciousness, vomiting for many times, and bleeding from left ear and all, past history of medical significance. On examination, he was ill. He had the first examination 6 hours after the incident, the insult. He has been ill, irritable, blood pressure 220 over 120, was comatose, Glasgow scale was 6. His chest was full of crepitation due to some inhalation. His abdomen was normal. He has right side weakness of grade 3 or. This is his CT scan. You can see here generalized brain swelling associated with subarachnoid hemorrhage and multiple frontal contusion and subdural hematomas, together with some petechial hemorrhages around the brain stem. He was put on mechanical ventilation plus oxygenation and given IV fluids, furosemide, imodubine, ceftriaxone, amlodipine, and nexium. 3 hours after starting of this treatment, the patient deteriorated and developed an attack of cardiac arrest. He developed low blood pressure and pupillary dilatation and loss of response to light, together with bradycardia. So when I saw him again, I stopped the furosemide and imodubine, and he was started on dopamine. He developed another attack of cardiac arrest, and he has been resuscitated and started to have blood urea and creatinine. Blood pressure become more lower. Here I checked the patient and I found him almost brain dead. He has no responses at all, the oculocephalic response of cornea and dilated pupils. So I made the diagnosis of brain death. But still, I could not stop the treatments. I have been contacted by a doctor from the family who also agreed to the diagnosis of brain death, and he asked me to stop the medications and supportive measures and not to proceed to any resuscitation if he developed another attack of cardiac arrest. But I was not agreeing on his opinion. Since I am not being protected by any law, if I have stopped these measures, to be condemned by killing this patient. So I continued on the same medication. The patient developed a third attack of a fourth attack of cardiac arrest 1 day later, and his heart stopped and announced death. The second patient is a 45-year-old man. He is from Khartoum. He is a retired teacher. He is referred from another hospital for mechanical ventilation. He has history of deterioration in level of consciousness following session of renal dialysis. He is a known case of renal failure. And after a session of dialysis, he developed respiratory failure together with deterioration of consciousness. He has past history of renal failure on dialysis for a few years. On examination, he was comatose. His Glasgow coma scale was 3. He has high blood pressure. He has no spontaneous breathing. He has bilateral effects and dilated pupils. The CT scan showed this aggressive type of bleeding involving all the ventricular system and it's associated with generalized brain expansion. So I made the diagnosis of brain after confirming it by test, not confirming test, but clinical test of cerebrocephalic and corneal reflex, and stopped the ventilation for a while. I couldn't find any respiration. So I made the diagnosis of brain death. I have been confused what to do with the patient. I started on ceftriaxone and just nasogastric tube feeding. The patient was in private hospital. The relative asked me to transfer the patient to the public hospital to reduce the expenses on them. The patient, the same day, I promised them to, since the patient needs ventilation, you cannot find any empty ventilator in a public hospital easily. He developed high blood pressure and high blood urea, high creatinine. Together with low blood pressure, and started on dopamine, and his heart and the certain clinical death occurred 3 days later. So brain death is an irreversible unconsciousness with complete loss of brain functions, including the functions of the brain stem. The brain dead individual has no clinical evidence of brain functions upon clinical examination, and this includes no response to pain, no spontaneous breathing or respiration, and no cranial nerve reflexes, including pupillary reflexes. He has fixed dilated pupils, also oculocephalic reflexes, corneal reflexes, and has no response to caloric reflex test. The heartbeat might continue to function in a brain dead individual. Until late 20th century, brain death was defined only, death and not brain death, death was defined only in terms of loss of heart and lung function, and not the brain functions. But with modern technology, these functions can be maintained even when the brain is dead, although the patient recovery is not expected. The French neurologists were the first to describe brain death in 1959, and followed by the American doctors who described the case in United States in early 60s. There are many causes for brain death, but in our neurosurgical practice, we find the common causes are traumatic brain injuries like large cerebral or subdural hematomas, diffuse brain problems like diffuse brain edema with absent basal stems, fissure, and sulci, diffuse axonal injuries, and multiple hemorrhagic contusions.